Today, lithium, the most studied drug in psychiatry, what it does, and what clinicians need to know. A patient comes to clinic nervous about starting lithium. I've heard lithium is dangerous. Is it really worth it? Lithium is a monoionic salt, not an antidepressant, not a benzodiazepine. FDA approved for acute mania in 1970, it's one of the oldest psychiatric medications still in active use. Over 60 years of evidence supports its role in acute mania, bipolar maintenance, and as augmentation in treatment-resistant depression. The catch: it has a narrow therapeutic index. That is why monitoring matters. 3 key mechanisms set lithium apart. First, SGA3 inhibition, supporting neuroprotection and mood stabilization. Second, increased BDNF, promoting synaptic plasticity and antidepressant effects. Third, modulation of serotonin, norepinephrine, and glutamate without sedation or dependence risks. These effects build gradually over weeks, not hours. For acute mania, lithium has the strongest evidence base of any mood stabilizer. A 2013 BMJ meta-analysis found it most effective, NNT approximately 3 to 4 versus placebo. It requires blood levels of 0.8 to 1.2 milliequivalents per liter and 1 to 2 weeks for full effect. Antipsychotics work faster, but for patients who can tolerate it, lithium often produces the best quality response. For bipolar I maintenance, lithium remains the gold standard. The landmark Gellenberg trial showed it reduces depressive relapse. CANMAT 2023 lists it as first line. It prevents both manic and depressive episodes, unlike some alternatives that work better for one pole. Maintenance target is 0.6 to 1 milliequivalents per liter. For bipolar II, the evidence is less robust, and monitoring burden may outweigh benefits. Now for one of lithium's most underemphasized properties, its anti-suicidal effect. Multiple meta-analyses, including a 2024 review by Zhu and colleagues, confirm that lithium significantly reduces suicide attempts and deaths in bipolar disorder. This effect is not seen with comparable consistency in valproate, lamotrigine, or carbamazepine. When treating a patient at elevated suicide risk, this may be the most compelling reason to persist through the monitoring burden. Lithium is also used as augmentation in unipolar treatment-resistant depression, off-label, but supported by NICE NG 222. The dose is lower than bipolar treatment, typically 600 to 900 milligrams per day, targeting 0.4 to 0.6 milliequivalents per liter. NNT for remission is approximately 10. For patients who have failed multiple antidepressants, this remains a valuable evidence-based option. Lithium's narrow therapeutic window makes monitoring non-negotiable. Acute range is 0.6 to 1.2, maintenance is 0.6 to 1 milliequivalents per liter. Toxicity begins above 1.5. Blood levels must be checked after any dose change, dehydration, or new medication. Extended-release formulations smooth out peaks and troughs compared to once-daily dosing. 2 organ systems require regular monitoring: kidneys and thyroid. Baseline labs include creatinine, BUN, urinalysis, and TSH. Then every 6 to 12 months. Hypothyroidism occurs in approximately 20 to 30% of long-term users, manageable with thyroid hormone replacement without stopping lithium. Renal function also needs ongoing tracking due to the risk of nephrogenic diabetes, insipidus, and chronic kidney changes. Lithium toxicity progresses in stages. Early, nausea, diarrhea, fine tremor, polyuria. Moderate, confusion, slurred speech, coarse tremor. Severe, seizures, coma, cardiac arrhythmias. Dehydration is the most common trigger, from vomiting, diarrhea, fever, or heat exposure. NSAIDs are particularly dangerous. They reduce lithium clearance and can push levels into the toxic range. Patients on lithium should avoid NSAIDs or use them only with close monitoring and dose adjustment. Several drug classes raise lithium levels. ACE inhibitors and ARBs reduce renal clearance. Check lithium levels within a week of starting. Thiazide also increase levels. SSRIs carry a theoretical additive serotonergic effect. Monitor for serotonin syndrome signs: tremor, hyperreflexia, clonus, agitation. Consistent hydration and avoiding dehydration are the overarching rules. Does lithium compare to alternatives? Valproate works faster, but carries weight gain and teratogenicity risks. Lamotrigine is excellent for bipolar depression prevention, but not for acute mania. Carbamazepine has significant drug interactions, and requires hematological monitoring. Second-generation antipsychotics work faster but carry metabolic risks. Lithium's advantages: proven maintenance efficacy, distinctive anti-suicidal effect, and 60 years of track record. Here's the bottom line. Lithium is the most studied drug in psychiatry. Gold standard for acute mania and bipolar I maintenance, with a distinctive anti-suicidal effect not reliably seen in other mood stabilizers. Also effective as off-label augmentation for treatment-resistant depression. It requires consistent monitoring of blood levels, renal function, and thyroid. For the right patient, elevated suicide risk, able to maintain the monitoring regimen, it remains irreplaceable. Questions about today's content or topics you'd like to see covered in future episodes? Drop them in the comments below. And if you found this clinically useful, hit subscribe. More psychopharmacology breakdowns are coming. This video is for educational purposes only and is not a substitute for clinical judgment.